Okay, well, I'd like to welcome everyone to the first May meeting of the IMAG-MSM Working Group on Multi-Scale Modeling and Viral Pandemics. As usual, I need to remind you that this meeting is being live streamed on YouTube and it's being recorded for posterity. And so people should be aware of that. We have two great speakers lined up today, both talking about somewhat translational work. I think we wanted a lot to have translational speakers, and so that I'm very pleased that we have that opportunity. As usual, James Glazier here is co-lead. Reinhard Wabenbacher isn't here today. It's one of the rare times he's missing one of these meetings. We have Dr. Jim Sluka on the call, and also Bruce Shapiro, Dr. Bruce Shapiro, both of whom you've had interactions with, I'm sure. Our emails are here, so if there are any complaints, criticisms, suggestions, you can always reach us. As always, you've heard me say this at the beginning of every meeting. We have a variety of social media channels. We have a LinkedIn page. We have a Twitter account. We have a Slack channel. We have a YouTube channel. And we also have a Facebook page. Please take advantage of these means of communication. We would especially appreciate your help in getting word out about these seminars so that they get the attendance and the viewing that they deserve. And now we have opportunity for announcements. Does anybody have any announcements of conferences, funding, publications, requests for help, anything, any short announcements that you'd like to make? John, did you have anything you needed to say today about your project?
Thank you. We have submitted a proposal from the dissemination and outreach subgroup to the NIH program manager, and that is to conduct a virtual annual meeting for IMAG MSMC. The proposal's been submitted, waiting to hear back. And I'd say it's like when you're building a puzzle and maybe we've kind of sorted out the colors of the pieces on different parts of the table. And if we get the approval to go forward, it's going to take a lot of help from a lot of you to put the pieces together.
Okay, thank you, John. All right. Any other announcements before we continue? No. Okay, so our immediate upcoming meetings, next time we will have, rather than regular seminars, we will have reports from two of our subgroups. We will have John talking about his extensive work on dissemination outreach and talking more about the meeting that he's organizing. And we'll have Fred Adler talking about the viral evolution. May 20th, we have a single speaker, Rusty Irving, who was one of the developers at GE of the digital twin concept. We've talked a lot about digital twins in biomedical applications, and I think it will be very interesting to hear about the history and applications of the original engineering digital twins. May 27th, we have Philip Ball, the noted science writer, former editor of Nature, who will be talking to us. And then coming up, we have a variety of interesting scientific speakers. As always, we would appreciate your suggestions for future speakers, topics, and connections. As usual, we will hold the questions till after both of the speakers have finished so that we make sure we get through the both talks during the main meeting. If there's time for questions during the main meeting, please keep them general. And if it looks necessary, I'll break in with a 5-minute warning for our speakers. We don't typically do elaborate introductions to save time, so I will turn over the floor to Natacha Go from Novadiscovery in Lyon, France, who's going to be talking us about application of a mechanistic model to design RTI prophylaxis trials.
Yeah. Thank you very much for this introduction. So I'm going to share my screen. Can you all see it? Great. I just would like to take this opportunity to very briefly introduce Novadiscovery company, because I'm pretty sure most of you don't know what we are doing there. So we are developing Insidico approaches mainly to help the optimization of clinical trials. We have a mechanistic approach really based on the knowledge, biological knowledge, rather than based on data. So it's why we call it white box, in a position on what we can call a black box when it's more data-based and statistical approaches. And we really want to bring some transparency in everything we do. So about all the synthesis of the knowledge from the literature, but also all the equations of the model, how we calibrate the model, everything. So yeah, this is main outlines of what we do there. So now I'm going to talk about the application of a mechanistic model to design RTI prophylaxis trials that has been conducted by a team at Novadiscovery and in collaboration with a pharmaceutical company, which is called OM Pharma and which is based in Switzerland. So first, about respiratory tract infections, so RTI. I'm only going to talk about the viral one, and viral RTI in children are associated with hospitalization, wheezing, and asthma inspection. So this is a kind of big issue for, at least for children. And about the prevention, there is no vaccination available currently, and neither in any future. However, we have some promising non-specific immunomodulation for RTI prophylaxis. And in particular, today, I'm going to focus on the oral bacterial lysate that's called Broncho-Vaxom, or a short name OM85. So what's about this treatment, the oral bacterial lysate? In a number of countries, OM85 is approved in the adult and in pediatric population for the prevention of the recurrent respiratory tract infection. So that's well, let's say a kind of consensus of the definition of the recurrent RTI is about more than 6 RTI per year. So it's quite a lot actually. And here in this plot, you can see an illustration of the effect of this treatment on the number of RTI per year that has been meta-analyzed in a study from Lyon et al. In 2018. And that represents the number of respiratory tract infection without the treatment in the x-axis. Compared to the number of RTI with the treatment in a year, and in the plot, each square corresponds to the mean of a given study, and the bars correspond to the standard error. And there you have the dashed line that represents the null efficacy line. And then, of course, if you are above this line, that means that the treatment is efficient. And the farthest you are from this line, the highest is the treatment efficacy. So you can see that this treatment is pretty efficient. However, further development and market access for OM85 is required to confirm the efficacy of the treatment. And this is mainly because of the large heterogeneity reported in the efficacy due to the included at-risk populations, so depending on age, depending on atopy risk, depending on the risk for recurrent RTI, but also the efficacy varies depending on the follow-up period, the regimen of the treatment, the endpoint. So here I show you the number of RTI over year, but will be also measurement of the wheezing. And finally, it also fluctuates depending on the RTI burden fluctuations. The new efficacy data are needed, but clinical trials are strongly impacted by the pandemic, of course. And here on the right, you have two graphics. So the first one on the top represents the incidence of the common cold in UK. So the dark blue line represents the mean, the average over 5 last year. And here the different lines represent the incidence for the 20 to 21 year, depending on different region. And what you can see is that it starts very similar than the 5-year average, but then it goes down when the lockdown starts. And then on the other graphic, that's the data from North America. Each line represents the number of positive influenza tests per week for the different years that have been reported. And in red, you can see the curve for the year 22 that start similarly than the other one, but then goes down to 0 when the lockdown starts. And for the year 2021, so this year, they have reported no positive case for the influenza. So in this context, we propose an Insidico approach as a first step towards the design and feasibility forecasting for RTI prophylaxis trial. And we have implemented a dedicated Insidico approach using a multi-scale mechanistic model. This is the global picture of the model. So we have, in this model, we have something to represent the administration of the treatments and the response to this treatment in the context of respiratory tract infections. Or on the left, you can see the part concerning the treatment. So when you take the treatments, it goes into the body, reach the gut, where it activates the non-specific immune response. Some of the immune components circulate through the systemic circulation and can finally reach the lung, where you can be exposed to a different set of viruses. So you get a viral challenge. And of course, the probability to get a viral challenge is reduced in a context of lockdown. And then we have the disease model. So what's going on in the respiratory tract in this context. So this is basically a quite complex immunological model. So this is a very simplified view of the model. I'm not going into the details, but you have the basic different subtypes of the adaptive response with the neutralization of the viral particles, the release of the infected cells, and immunomodulation of the inflammatory response, which is responsible for the symptoms. And the interaction between the immune system and the virus will define the viremia over time, which is represented in this plot here on the very bottom here and right bottom, where you have so the viremia over time for each viral challenge, which is represented by a very small virus on the bottom of the plot here. And what we did to define if the patient is experimenting an RTI or not is we impose a threshold of infection development, and once the viremia is reached this threshold or is above, we say that this is a RTI, and when it's below, there is no RTI, and thus we can compute the number of RTI over a year, which is represented by this green curve here. So it's just incrementing each time you reach or are above the threshold. Okay, and now we want to model the impact of COVID containment measures on viral challenge. So to do so, we have a SARS model to define the probability to be infected. So it's a very classical one where you have susceptible population that can be infected and recover and then lose immunity, so can be susceptible again. And under lockdown, we assume that reduce the transmission rate between individuals, basically because you have less contact and because also of the measures of social distancing. And so we vary the infection rate, and at the end, based on the number of infected people, we deduce the probability of infection. We will determine the viral challenge, and at the end, choose the disease model, the number of RTI you are experimenting. So based on this SARS model, we are able to reproduce the probability of upper and lower RTI challenges under lockdown. So this is an illustration of the model calibration compared to actual disease burden, well, not actual because it was 2022, but so from UK. And so you have the probability to be exposed to a lower or upper RTI over time. The dotted line is the model simulation, and the points with the plain line is the data. And you can see that our model simulations fits pretty well with the data. Okay, so now we have the model. It's able to reproduce the probability to get viral challenge on the lockdown, and we want to use it to explore the influence of lockdown on clinical trial design. So to do so, we generate what we call virtual population by varying some parameter characterizing the individuals. So, for example, the level, the immunocompetence level, by varying the seasonality and also depending on the random components. So that will be the different characteristics or related to that represent the viability. And to design the Insidico trial, we have an observational period of a year where the different patients are exposed to different viral challenges. And then we have a follow-up period of a year again with the treatment at the beginning of this year that usually stays for, well, we have 3 months of treatment, and then we just keep monitoring the patients. And from the results of this Insidico trial, we do some analysis. So first, we define the inclusion criteria for the trial based on the observational period, and then we compute the number of respiratory tract infection for the control arm and the treated arm. And this way the file we compute the inclusion criteria on the observational period relies on the hypothesis that there is a strong correlation between the number of RTI you will have in a year and in the next year. So the idea is that if in the last year, let's say you are below the average, you expect to be below the average the current year as well, and the same if you're above the average, of course. So this is the global view of the methods. And when we do that with the model, we do the Insidico trial exactly as I showed you right before, and what we get is this plot I show you at the very beginning of the presentation, if you remember about the efficacy of the treatment. So you have the number of RTI in the control arm for a year and the number of RTI in the treatment, for the treatment arm in the year. Here you recognize the data I show you at the beginning in the blue square, and then each small colored cross represents our simulated data. The color stands for the inclusion criteria. So it goes from 0 to 10, and it's based on the observational year. And each cross doesn't represent a single virtual patient, but it's the mean of a group of 50 patients. And what we can see is that the model simulation fits pretty well to the data. And now we will do more or less the same, but with a bit more analysis in context of lockdown. So for that, we apply the same methods for the Insidico trial, but during the follow-up period, we assume that we can have lockdown that can be of different strengths, so from very severe one so to very severe one, or mild one, or even no lockdown. And we do the same analysis, but this time we impose an inclusion criteria of the number of RTI during the observational period should be at least of 5, because this is the criteria that is used in the clinical trial, because of course you want to show, well, you want to target some patients that are exhibiting some recurrent RTI. So this is why we use this inclusion criteria. And what you can see in this plot is always the same. So number of RTI for the control arm and number of RTI for the treatment arm. With the different lockdown scenarios. So the pink one is a no lockdown, and this one is the strongest lockdown. And as expected, the strongest is the lockdown, the lowest is the is the number of RTI.
Just 5 minutes.
Okay, thank you. In both control and treatment arm, and then you see here the efficacy of the treatment, and of course, if you have very few respiratory tract infection, the efficacy of the treatment will be low as well, because you already have very few episodes. So now we want to do that for the sample size of the trial. So we do the same Insidico trial, and we computed the sample size on this criteria. We want that the efficacy of the treatment, well, the reduction of the risk to have RTI episodes should be at least 20%. So that's what we do, and from that we are able to assess the sample size that will be needed to reach this criteria. And what we see is that depending on the lockdown scenario, so from absent to medium scenario, you don't really change the sample size. But when you have a very strong lockdown, that increases a lot the sample size. And this is very easy to understand when you go back there, because you need to reduce you need to have 20% efficacy. Risk reduction, risk reduction, so which is reached here with the medium scenario, but here with the strongest lockdown scenario, you can see that the risk reduction is much lower. So this is why you need to increase a lot the size of the sample size of the clinical trial. And finally, we want to explore the time we need to recruit the people for clinical trial. So we only look at the observational period because this is where you will, the time during which you will recruit the person. The inclusion criteria is still the same. And we compute the time to recruit in order to get patient enough with this inclusion criteria. And what you see here is that with the no lockdown, you will recruit enough patients in less than a year. But then if you have a mid-lockdown scenario, you will need a bit more than a year to recruit all the patients. And then with only a medium lockdown scenario, you will need more than 8 years to recruit all the patients. So I'm done with the results. I would like to highlight a few things in the conclusions. So I show you a mechanistic multi-scale model for RTI and oral bacterial lysate treatments based on an extensive literature review and synthesis. Insidico data aligned with experimental data, which consisted in that case in vivo, in vitro, in vivo preclinical and clinical, as well as epidemiological data. There are various potential application and extension to this work. It can be applied to different viral respiratory tract infection in general, so including coronavirus. It can be applied to viral infection as wheezing and asthma triggers, can be applied to viral infections triggering exacerbation of idiopathic pulmonary fibrosis and COPD. This approach is robust to assess a wide range of applied and research questions in clinical development. So for example, we can explore the dosing regimen, the sample size of the clinical trial, some surrogate markers, model hypotheses in link with knowledge gaps. And finally, well, I hope I've been able to convince you that can bring inputs to assess the feasibility of RTI prophylaxis trial in context of COVID-19 pandemic. Thank you very much for listening. I would like to thank OM Pharma again for the collaboration and for the funding, and as well as I would like to thank all the people that work on this project inside NOVA. And yeah, I will keep your question for later if I correctly understood.
Okay, thank you. I think that wonderful talk. Wonderful to see these ideas being used in a translational context. We really appreciate it.
Thank you.
So let us move on now to our second talk, which is Joshua Schiffer from the Fred Hutchinson Cancer Research Center, who's going to be talking about modeling of SARS-CoV-2 shedding therapy and transmission. So potentially a nice match to the first talk. And I'll turn it over to you without further ado.
Great, great, thanks. So I'm going to just share my screen. And let's see. So please just let me know if you all cannot see the screen, but otherwise I'll get going. I think we're okay here. So it's a real pleasure to speak to this group. It's a great opportunity, and I really appreciate it. You know, typically when I give a talk, we will do a deep dive on one of the subjects I'm going to cover today, but I'm going to really try to cover the extent of the work that our group has done over the last year, and it's very broad. So I apologize for not getting into the technicalities of virtually any of these projects, but I figure there may be some great opportunities for collaboration. So I really want to expose the group to the full scope of our work. And so there are really three broad categories of models we've worked on. The first is modeling intrahost biology and looking at viral loads of SARS-CoV-2 within a person. The second is looking at the epidemiology of SARS-CoV-2, particularly in our region, in the state of Washington, and in particular King County, where Seattle is. And then the third, where I'll spend most of my time today, is looking at the interface between these two and looking at the relationship of viral load and transmission. And so the team that's looked at viral load and transmission is here, and I give them all of the credit. This is Brian, Ashish, Fabian, Dan, and Judy. And so our group's bread and butter is intra-host modeling and looking at viral loads. And so this is really the first thing we did back in March of last year. And what we have here is a basic intra-host model that has variables looking at susceptible cells, infected cells, immune responses, and viral load. And we generally try to fit competing models to the data. The data is gathered from numerous locations throughout the world and is represented by the dots in each of these panels, each of which is a study participant, and then the line is the model. And we had a pretty good model that is able to generate the heterogeneity and viral load that we see in these multiple study participants. And very briefly, we did have some scientific conclusions from this work, which has been published for some time now. The first has to do with the timing of different components of the immune response, which is represented with this blue line here, that we think most of the infected cells are getting killed by the innate or non-specific response to the virus in the first several days of infection. But starting at about a week, the acquired immune response kicks in, which consists of either antibodies or T cells. And subsequent work that Judy did, which I'm not showing today, really shows that the arrival of antibodies is too late to explain this clearance. So at least during natural infection, we think T cells are probably very important for the clearance of the virus. And then a practical result of this modeling is on the right, we have simulated antiviral therapy, and the black line represents no therapy, and the green line represents a very potent drug. And we wish to make this point very early in the pandemic. I'm a clinician as well, and this is just something we've known for all viral infections that we've tried to treat, that early is better. And one very gratifying result of this is at the Fred Hutch, we've actually built a research treatment center where we're now involved in 7 clinical trials, each of which requires participants to be at high risk of developing severe COVID, but also that they've only been symptomatic for less than 72 hours. So we're trying to catch people before that window where they're at risk of hospitalization and death. And so it's been one gratifying result of the modeling where we've been able to take this concept forward. But moving on to transmission, there are several questions which we wish to get after. The first of which is what viral load is required to facilitate SARS-CoV-2 transmission? Why is SARS-CoV-2 more predisposed to super spreader events than other RTIs, including influenza? How can we optimize masks with this knowledge? Are antiviral therapies potentially useful to prevent transmission? And how about vaccines that prevent transmission but not infection? Can we conceptualize this in terms of viral load? And so the reason we think that viral load is important is based on tons of animal data. The most relevant is, the closest we've seen is with SARS-CoV-1, the original SARS in mice, where challenge dose is very predictive of the likelihood of the animals developing infection. That's shown here, both with the raw data in terms of dots. The x-axis is challenge dose on a log 10 scale, and the y-axis is likelihood of developing infection. And in all of these experiments with other viruses, you can generate an infection probability curve or a transmission dose curve here. And we've been in this space for a while looking at human herpes viruses, and we had this fantastic data from Uganda where we measured human herpes virus shedding in every member of households and saw in a very predictable way for a couple of viruses that the amount of virus being shed, the viral load being shed either by mothers or siblings, was very predictive of whether the infants would develop HHV6 in particular the next week. And so this is sort of a real world transmission dose response curve. And so we started with this concept, and we constructed a mathematical model that started here in the pink is the heterogeneous viral loads that I showed you before that we can generate with our model. And then we modeled various timings and intensity of exposures and assumed that there was some relationship between viral load and transmission. And what we did was we really tried to find the best data to fit our model to. And there was two distributions that we thought were extremely interesting that contrasted SARS-CoV-2 from influenza. The first is something that we called the individual reproductive number. So we're all familiar with the concept of the total reproductive number. But one of the interesting things about SARS-CoV-2 is that most people who get infected don't infect anybody. It's on the order of 70 to 80%. This number is much lower for influenza. And so you can capture this with a frequency histogram. But with SARS-CoV-2, as you all know, there are these much less common people who can infect tens, dozens, or even on a rare occasion, hundreds of people. And this virtually never happens with influenza. And so our model was able to reproduce these histograms as shown here with the observed and simulated data. Similarly, the serial interval, which is defined as the time between when the infected person develops symptoms and when the secondarily infected person develops symptoms, also is associated with a distribution. And for influenza, it's sort of what you'd expect. It's always positive. It's a fairly narrow distribution. A few days after the infector feels sick, the secondarily infected person feels sick. What's interesting about SARS-CoV-2 is that the mean and median are fairly similar relative to influenza, but the distribution is much wider. And that's because SARS-CoV-2, unfortunately, has a very variable incubation period. And so, for example, you could have a situation where the serial interval is negative, and this has been observed repeatedly, where the first person to develop symptoms in a household was actually not the first person to get infected. They just had a shorter incubation period than the person who infected them. And so our model was trained to reproduce this as well. And so the scientific conclusions we came to based on this were that there is likely to be a transmission dose response curve, both for SARS-CoV-2 and influenza. But in these simulated viral load tracings for both viruses, what these heat maps refer to is the transmission risk associated with time. And the red bands, or the dark blue, indicate an increased transmission risk based on viral load. And so the point that came out of this was that people are actually probably not contagious for very long, that there's this very narrow window consisting of a day or two where they're shedding at high viral loads. And as a result, when you detect somebody with a positive test, particularly if they have a low viral load, they may not be contagious at all. And this was actually quite similar for the two viruses. And if you then look at the transmission risk, which is shown here as a function of days since exposure, the two viruses actually look quite similar. That the solid and dashed lines just represent the proportion of people in our model who have these different transmission risks. But I'll ask you just to focus on the timing. And days since exposure, the two viruses are markedly similar. But if you then recalibrate to look at days since onset of symptoms, what you notice is that the red curve shifts to the left and is peaks before day 0. And this gets to the real problem of SARS-CoV-2 epidemiology, is that most people who transmit are in the pre-symptomatic phase of infection. And this is one of the reasons it's been so incredibly difficult to contain this virus globally. Whereas influenza, the curve looks very similar to the days since exposure. So most people who transmit have developed some symptoms. So next we moved on to try to explain super spreader events. And here we thought that there were really two competing hypotheses. The first hypothesis was that people who have SARS-CoV-2 shed the virus for much longer than those who have influenza. And so maybe they can just infect more people because they have a longer window of potentially infecting people. The second hypothesis, the way I configure this is, imagine you have a room that is a great super spreader event, poorly ventilated, crowded, nobody's wearing masks. One hypothesis would be that the person with SARS-CoV-2 who enters that room could potentially infect a majority of people in that room, whereas a person with influenza might not. Maybe they just infect the people within a closer window. And hypothesis 2 ended up being heavily favored by the model. I admit that I was biased going in, because if we look at history and we look at SARS-CoV-1, there was this incredible data from the Amoy Gardens complex where there was a viral load and space-dependent relationship across buildings. So people were infected There was an index case in one building. There was a wind flow from this building across the courtyard to the other building, and people in these other buildings got infected with a very clear index case and an N of 1. And this cannot happen with influenza. So this was a very, very clear indication that coronaviruses are predisposed to aerosolization, and in my view was ignored for way too long. But then looking at our model output after being fit to the data, when you compare SARS-CoV-2, what each of these dots represents on this plot is a transmission event from one person infecting another. And the color of the dot represents the number of secondary transmissions. And there are two variables that go into this. The first is the exposure viral load on the x-axis. And the second is the number of exposed contacts that that person has. And so here you see these maroon dots are these very rare super spreader events where close to 100 people get infected. And the two prerequisites for this are the person shedding must have a very, very high viral load, but also they must have 100 exposure contacts. So they had to be in that room. For influenza, the viral load is shifted to the left based on details of the assay, but essentially you still need a high viral load. But you see that it's not even possible in most cases to have a high number of exposure contacts. And so this to us spoke to a biological difference between the virus, that one is more prone to aerosolization and super spreader events than the other. What these plots are getting at is the overall contribution to total number of infections, or the overall contribution to R naught. And so again, the x-axis is looking at the viral loads, and the percent of total infections has to be above a certain viral load for both viruses. But then the y-axis looks at events where the number of infections generated by a single person falls within these categories. And you can see that for SARS-CoV-2, anything over 11 people, so an 11 to 100, contributes to the majority of infections, whereas for influenza, it falls much more between 2 and 10. And so one of the points we make in this paper is that if you could eliminate super spreader events, if you could eliminate events where more than 10 people get infected, the virus could not sustain itself in the population. And so the conclusions of this work, which is published now is in eLife, is that there's this very brief period of transmissibility for both viruses. But for SARS-CoV-2, super spreader events really involve the wrong person at the wrong place in the wrong time, meaning high viral load where there's a lot of contacts in that area. We don't think that additional 1 to 2 weeks of shedding for SARS-CoV-2 contributes much to transmission or to super spreader events. And we feel like our model favors aerosolization as a key driver of the epidemic. One recent expansion of the model is we've looked at introduction of new variants into the population. And so these are just some raw data from the simulations where we start with a baseline variant that starts with an effective reproductive number of 1. You can tell it's a stochastic simulation, and you see this black sort of stable line. And then we introduce different variants that have different reproductive numbers that are generally higher, and also are introduced randomly. And the conclusion we came to in this model is that the effective reproductive number of the new variants is important, but what's actually most important is an early super spreader event. And so what we're showing in this correlation plot is the day of the first super spreader event, which we define as any event infecting greater than 20 people, is highly determinative of the time it takes to get to 1,000 cumulative infections with that new variant. And so the public health message here is that we need to continue to be vigilant against preventing these events. So it was quite easy to expand this model to include masks. The idea would be that masks worn singly, either by the transmitter or exposed person, would lower exposure viral load, and worn in duplicate would lower it further. And so you can imagine a counterfactual situation in which a person would have infected 9 out of 10 people they're exposed to without a mask, but maybe if either the transmitter or the exposed person is wearing masks, that decreases that number a little bit. But then if both are wearing masks, you might decrease transmission, not entirely, but altogether. And what we did here was we varied 2 things. We were in panel C, we have 75% of people wearing masks 75% of the time. In panel D, 90% of people wearing masks 90% of the time. And then we just looked at different assumed efficacies of masks. And the contribution to overall are not. And as you can see, as you increase the efficacy of masks under both situations, the reproductive number goes down. And then if you compare when more people are wearing masks, so at a comparable efficacy, the reproductive number is lower. And so what we think of as masks, I've done a lot of work in the STD world, is we think of these as highly imperfect condoms, but that they actually have great indirect effects in the population by lowering the force of infection, very contingent on the number of people wearing them and their efficacy. The final point is that we break each of these towers into super spreader clusters. And so you can see those labeled here. And essentially the bottom 3 clusters involve events infecting more than 10 people. And so you can see that the masks have a disproportionate effect on lowering super spreader events. And by doing so can get the reproductive number less than 1. The final point we made in this paper, and I won't go through the graphs because it's a little involved, but is that even if they do not prevent infections, particularly in the context of dual masking, the model makes the prediction that the exposure viral load among infected people is lower. And so it raises the hypothesis that's been raised by others, but not yet validated, that masking could also prevent the severity of illness among those getting infected. So a dual benefit of masking. So we think that slight increases in mask use and/or efficacy would significantly lower the effective reproductive number, particularly if targeted towards people with high numbers of daily exposure contacts, either through high-risk work or, less good would be social events, and that dual masking could lower exposure viral load. We extended the model also to look at antiviral treatment. So in the HIV world,
Cut in and say 5 minutes, please.
Okay, great. I think we're doing okay. So in the HIV world, antiviral treatment to prevent transmission is a popular concept. And in fact, lowering the community viral load lowers the force of infection and can really prevent transmission in the community. With antiviral therapy for SARS-CoV-2, we do not think that is the case. And the reason we don't think that's the case is that by the time most people would receive antiviral therapy, they're symptomatic. And so when we look at treating even 100% of people at day 5 after their exposure, it really doesn't lower the effective reproductive number very much. On the other hand, if you could really institute widespread post-exposure prophylaxis very soon after infection, you might indeed lower the reproductive number. And so there might be some use for this in high-risk environments, at least in the pre-vaccine world, such as skilled nursing facilities. The final piece we looked at is vaccine efficacy and its effect on viral load. And so you can imagine that there are different types of vaccine efficacy. One is complete protection against infection. So that's called vaccine efficacy against susceptibility. And that's brilliant because it not only protects the person, but that person never sheds the virus. And so they're a dead end for transmission. But it's possible that the person may be protected against symptoms, but still develop infection. And in that case, their viral load might lower. And so they might infect fewer people than they would have before. But maybe if their viral load is lowered sufficiently, they won't infect anybody. And so the vaccine will have profound indirect effects. And so one piece of modeling we did was to try to estimate the amount or the reduction in peak viral load that you would need to achieve these levels of vaccine efficacy. And it doesn't seem that much. It seems like you could get 50% reduction in infection just by lowering the peak viral load by a little over half a log. And so we've really been advocating for testing this both in animal models and human challenge models, because this is just a model prediction that needs experimental validation. So I'll end with our epidemiologic modeling, and I don't think I'll go through every slide here, but it's a different team here. Chloe, Dave, Dobromir, myself, Mia, Dan, and Eileen have worked very closely with the Washington Department of Health and are grateful for funding through the CSTE. And essentially, we have an SIR model that has many of the features that you would be familiar with this type of model, where we have categories of susceptible, exposed, asymptomatic, pre-symptomatic, symptomatic, hospitalized, recovered, dead, et cetera. and we have a data-informed physical contact network. And we essentially recalibrate the model to existing data from King County, Washington, and we're very keyed in on these waves of infection that you can see here. We are now in the midst of our fourth wave, and the model is calibrated through April. Here it's just calibrated through January. And we do this in an age stratified fashion. So for kids, young adults, middle-aged, and elderly, and fit both to concurrent data and cumulative data. And we've done this for cases as shown here, but also for hospitalizations and deaths. And then we look at 4 groups of variables. The first has to do with the efficacy profile of the vaccines. As I discussed before, protection against susceptibility, symptoms, or infectiousness. The second has to do with the vaccination rate. The third has to do with social distancing policy. So in the state of Washington, we have different case thresholds for partial lockdown. We have different case thresholds for partial lockdown release. And then we try to estimate the amount of social distancing that actually happens during lockdown, and that happens when we're not in lockdown, but people are still somewhat vigilant about masks. And then we incorporate this piece of the new variants that are defined by 3 things. I neglected to include 1, infectivity, their importation rate into our county, but also, of course, their ability to dodge pre-existing immunity. And so this is just to show you what the model output would look like. The black lines are calibrated to the dots, which are initial data, and then we project beyond that point. And here's just like a single variable sensitivity analysis where we look at the effect of increasing vaccination rate on cases, hospitalizations, and deaths. Under almost all scenarios with B117, we predict a 4th wave that in terms of hospitalizations and deaths will not be as severe as what we endured over the winter. But there's a lot of levers to play with here, in particular with social distancing. So for those who are interested, we have this web page that was designed through a Shiny app where you can look at all of the projections for cases and deaths in various ways. And then there's a page where you can toggle the input variables in terms of the lockdown thresholds and social distancing, vaccination rate, and the degree of coverage to get different projections. And we're hoping, at the moment, it's a 2 variant model, but we're hoping to be able to capture B117 and P1 and B135 and whatever else comes concurrently in a data-informed way to really try to make projections as we move towards the winter and the sort of mystery of what's going to happen with the new variants. So that's it. I appreciate your time. I'm again sorry for flying through so much, but I hope this is a good stimulus for discussion later. I think you might be on mute. I'm not sure I can.
Sorry. Thank you again. That's wonderful. We'll have to have you come back another time and talk in more detail, especially to see how your predictions for the epidemiological models came out. So since this group has talked so much traditionally about in-host modeling, to see combinations of how you could combine in-host concepts through these infectivity studies with the epidemiological scale is really wonderful. Thank you.
Thanks so much.
Like James's internet is locked him out. So do we have any questions for either of the speakers? I don't know that he's done any breakout rooms, so let's just take some questions at this time for either of the 2 speakers. Jacob.
Okay, Josh, very good work, thank you. I have several questions. I'll start with the simple one. Did you actually incorporate the multiple infectiousness profiles that you have into your epidemiological model? Or is it something that you're going to do in the future?
Yeah, we have the model as it stands. When you go to the the page where you can adjust. The default is B117. And so we have the, which is now the predominant variant in our state. But you can also project what would happen if other variants were the predominant variant, including the baseline variant. And what's very striking and a bit depressing is that it doesn't look like there would have been a fourth wave at all had we not had new variants. So the increased infectivity is really, we think, driving the fourth wave. The one thing the model can't do yet is look at them concurrently. So we're able to look at two variants concurrently, but not all of them, and that's working.
This wasn't my question, but
oh, sorry.
Your answer is actually informative from other reasons. I'll let someone else ask questions, and I'll come back with more questions if there'll be more time.
Okay, sorry, I misinterpreted.
That's fine. The information you provided is important anyway. Thank you.
Okay.
Well, I guess that was the Zoom gods telling me that I should be quiet. So I will now. The timing is perfect. It's open discussion. Alan, please go ahead.
Yeah. So Josh, according to your model, infectiousness is determined by viral load. Is there evidence that B117 has higher viral loads to correlate with a higher infectivity, or is it some other property of the intrinsic property of the virus?
Yeah. Thanks, Alan. Good to see you. So the problem with the viral load data, in my view, is that it is very often gathered when people are symptomatic. And I don't think those are the key data points. There have been some really nice efforts, that I know Ruan has worked with the NBA data, but in my view, there's not yet a comprehensive data set that is trustworthy enough to look at the most critical time points, which is very early during infection. But that's not to say I could have missed something that's been released recently, but I haven't seen anything yet.
Do you know if there's any in vitro work to show that it's B117 is more infectious? Is the RNA to TCID50 ratio different, for example? Or
yeah, I want to say I've seen something, but I can't quote the source. Okay. I mean, to me, the most convincing data is the data from the UK is so incredible because it's this natural experiment where you have two variants exposed to the same degree of non-pharmaceutical interventions. Right. One variant is going up and the other isn't. So it's sort of a natural, I think ordinarily it's very difficult to infer causality from epidemiologic data, but I think in that case you can, because the experimental conditions are the same and one variant's going up and the other's not.
Oh yeah, no, so. I mean, it's clearly more fit. Then the question is, what's the nature? I mean, maybe it survives better in the atmosphere. Maybe aerial survives better. I mean, there can be other things rather than just intrinsic infectivity.
Yeah.
Or viral load.
Yeah, I think it has been shown in vitro, but I just can't remember the source.
Hey, Josh, John Rice. When you were talking about super spreaders in the room and you compared the influenza and CoV-2, you said something like there's something different about the biology, and that's the reason it doesn't happen. If you think in terms of the biology of the organism itself, what would be the one or two most important things that you can think of that you would like to know within a week of a novel virus showing up? What biological characteristic of the virus would do the most good to inform the front end of prediction models?
Yeah, I think it's a wonderful question. I suspect that if the question is aerosolization, I think it, to me, boils down to the virus's ability to diffuse over a longer distance in the air, because it lives in smaller particles, and also its ability to stay in the air longer. And it's some combination of those two things that makes coronaviruses apparently different from influenza. I'm not sure, I'm not a particle. It's not my area of expertise, so I don't know if you could figure it out that quickly. But I find myself wondering that when I'm in the grocery store, you know, if I'm walking down an aisle where I'm all alone, is the person who was there half an hour ago, did they in effect contaminate the aisle, contaminate the air in the aisle or not? And I just still don't have a feel for that. Maybe others in the audience do, but the question to me is why the virus aerosolizes, and if it's a duration or a extent of spread thing.
As many times as I've answered that, you're the first one that gave answers that sounded like something I might even understand. But that whole notion of the physics, the weight, the shape, the aerodynamic characteristics of the organism or in whatever it travels, well, we saw a lot of that projected. And it really is that determination of the distance that you're going to use for infection other than a wild ass, 6 feet.
Yeah.
And then serve, and you run 6, if it requires 2 feet, then a 6 foot SARS model is totally wrong. But the aerodynamic characteristics of the organism is interesting. Thank you.
Yeah, thank you.
I guess I wanted to ask a question. I would love to ask questions to both of our speakers, but I wanted to ask a question to Natacha because you're the first person who's really, we've had people who've gone to clinical trials with models, but you're the first person really to talk about clinical trial design with models. And one of the things that came up in both talks was essentially the issue of prophylaxis. And I wonder if you could talk a little bit more about, you mentioned in the trial design that you were evaluating, you were looking at a 3-month dosing period at intervals. If you were going to try to think about using the kind of approach that you're using in the context of SARS, how might you generalize that where you don't necessarily have a long-term prophylaxis, or maybe you do if you use, for example, an antibody therapy? Have you thought about what a clinical trial for a prophylactic treatment for SARS might look like?
Thank you for your question. Well, this is a very good question. I'm just thinking at the same time, well, I will say that so for this kind of very knowledge-based model, the main issue will be that you cannot really inform the model. I mean, even in terms of mechanisms. So then there is no way to assess the credibility of the model. So I don't really see a way to deal with this kind of context with this kind of approach. I will rather go with a very simplified model or even data-based model if there are some data. I don't know if that answers to your question, but.
One thing you didn't talk about a little bit was you showed a very nice in-host model that you used, and you didn't tell us much about how that model was calibrated. Can you tell us a little bit about how you did it, because it's quite a complex model?
Yeah, sure. So indeed,
if you need to screen share, you're welcome. You have the. If you don't, that's fine too.
No, I think it's fine. Well, let me know if it's unclear. I can show a graph, but I think it's fine. So indeed, the in-host model is an immunological model that's quite big. I have like about almost 30 variables and almost 100 parameters. And the issue with this kind of models is that usually you don't have a lot of information to inform the parameter values because of technical constraints, because that kind of stuff that you cannot really measure. And also because we are working on human, and then you have even less data, right? So indeed, this is an issue for calibration and validation. So what we did is the synthesis of all we can have to at least define some ranges or order of magnitude for the parameters. Then we made an extensive exploration of all the parameter space with some methods that are very powerful for this kind of model, where you really explore the interaction between the parameters. And with that, you end up with a lot of various behavior of the model. And then you still know a bit of the behavior you expect, or at least which one are realistic or not at all. So then you can reduce the parameter space and do that again and again, unless you end up with something that's realistic. So then you have realistic ranges for the parameters. And then in terms of calibration, I mean real calibration, what we did is only calibrate, we only calibrate on a viral dynamic because we have not been able to find any useful data to calibrate the immune components. But at least we did a semi-quantitative calibration, like we know that this component should peak at this time point, and this one is lower than this one, so this kind of things. That's what we did.
So then when you do your forward projections in the larger models, are you using single best fit values, or are you using ensembles of models when you're doing those predictions?
Yeah, so we calibrated on a mean response, like on a visual would be representative of an average response over a set of patients. And then from that mean, we calibrated the variability of the most influential parameters to be able to cover the variability observed in the data. And then when we make the prediction, we make the parameter value involved in the variability from the real world vary inside the ranges we defined from the calibration.
Thank you very much. Do we have any, as usual, I always
We've got two hands up.
Okay, Joy, why
go.
don't we go with you next?
I think Megan was asking first. Why don't you ask her first?
I'm sorry, Magna, I'm sorry, I didn't see.
Megan, sorry.
That's okay. Thank you for giving me the opportunity to ask a question. So I have my question to Dr. Schiffer. Thank you. That was a great talk. Just out of curiosity, I wanted to know, so your paper, which was published in 2020, how much of the reduction in viral load you think is dependent on the number of susceptible cells that are in the model? So I know that the model that was used was a target cell limited model. So how much do you think the reduction was mainly based on the number of susceptible cells that you start with in the model?
Yeah, great question. It's the target cell limitation is important in that model. The other feature of the model that in our hands provided better fit was that we have the death rate of infected cells is raised to a power such that, and we call that the innate response because it doesn't, it's merely dependent on the amount of infection at any given time. So those two things matter. I wish, as with a lot of viral dynamic models, I wish I knew whether that was actually true. I think that there becomes a very acute parameter identifiability issue when you don't really know the true infectivity in vivo, you don't really know the replication rate in vivo, and you don't know the number of susceptible cells in reality. And so, other groups have looked at modeling the upper airway, the windpipe, and the lower tract separately. Amber Smith's group showed us some really nice data doing this with parainfluenza, and that might be, an approach, and you can sort of estimate the number of cells, but I find it very difficult to to know whether target cell limitation is an issue at all. My group has done a lot of modeling with genital herpes, and we love modeling that system because in that system, first of all, herpes viruses are incredibly promiscuous, and so they can affect virtually all cell types. And second of all, we can visualize the infection and see with our own eyes that a tiny proportion of cells are getting infected. And so in that system, because it's a skin infection, I'm very confident making biologic conclusions about target cell limitation. But for SARS-CoV-2 and many other systemic viruses, I think it's challenging.
Okay. Do you think a sensitivity analysis would shed some light on it, or it's just a complicated thing that is difficult to just point out in the model?
Yeah, I think one of the things we should have done, and maybe we would have done if not for the rush, that paper was published in a unique time when everyone was sort of spazzing out, just like sending stuff to journals very quickly. But I pushed Ashish a lot to do this, to see if we could generate the same outcomes, assuming an abundance, a much higher number of susceptible cells. And unfortunately, Ashish has left the group, but I think that would still be a very valuable thing to do, to see if we could generate similar dynamics with an assumption of no target cell limitation. So it's a great idea.
Okay. Yeah. Thank you.
You bet.
So I guess I'm up. So also, for Dr. Schiffer, it's questions about masks, which thank you so much for that description. I will never be able to look at any of them the same. But, and this may be kind of random, masks versus social distancing. Is there any real benefit to 6 feet in a masked population? If you have 20 people in a room, is there anything beyond theoretical protection keeping people farther than probably normal body distance is, say, 18 inches, if they're all masked? We're repopulating back here in California, and it's something, believe it or not, our church is dealing with. How close do we let masked people sit together? Everybody misses each other. Everybody wants to sit by their friends. And so.
Yeah, my kids are having, I think this is at the national level, but my kids are sitting 3 feet apart in school now with
so
masks.
Mine, yet.
And they're all unvaccinated at the moment. So whether or not that is, I have not kept up with that. Unfortunately, one of the tricky things, and this, first of all, I don't think modeling can really answer that question, in my opinion. But one of the really tricky things with this issue that I showed very quickly of the overdispersed R naught of the virus is that because these events are relatively rare, the super spreader events, and because they involve the perfect overlap of somebody shedding at a high viral load and having a lot of people in a space. And, in our neck of the woods, the Skagit chorus outbreak occurred probably in half an hour. All of the infections occurred very quickly, certainly in less than 2 hours, but the people who were there really felt like they were congregated for a very short period of time. What that means in reality is that the absence of an event does not imply that it can't happen, and so I think a lot of the guidelines are based on, well, we've been doing this for 3 months and we haven't seen a major super spreader event. But first of all, they probably have seen a super spreader event, but nobody recorded it because we're in the middle of, some of these were documented better than others. So I think it's very hard to know whether 3 feet or 6 feet or any of that is totally right. And the type of modeling we do can't inform it. I think what our modeling does inform very clearly, and what I wish would have happened earlier, is that if you have an unavoidable crowded work environment, so typically that would be a work environment like a bakery or a factory where people must all be in a tight enclosed space and the ventilation's not good. Everybody should be wearing masks, and everyone should be wearing great masks, not not hospital masks, but KN95s or N95s. I think our modeling shows that very clearly, and other groups have shown that as well. So I think that's the tangible public health piece you can draw from this, but it's, at least from our work, the distancing issue is hard to get at. Sorry for the vague answer, but I just don't totally know.
No worries. It was a hard
Yeah.
question and
Yeah.
a bit beyond, but it was worth trying.
Yeah.
Josh, I kept thinking Occam's razor. Occam's razor. I mean, when you were presenting your results, the first reaction, but the scientific, philosophical ventilation, oh my goodness, the infection rate goes up.
John, I think you went out a bit right when you were, I missed, I think, the couple of things, maybe the key point. You try again.
Oh, no, I just said, when you think about it and your model shows that if you have a high viral load and somebody in a room with a whole lot of people where the ventilation's bad and they're moving around instead of sitting in the corner, there's going to be more infection. It's like, where do we get, what's the value of Occam's razor here? It's like, how complicated do we have to make the model to come up with something that just seems so obvious? And do we sometimes make a mistake of taking the obvious Occam's razor answer and building the model to get it?
Yeah, I agree. I mean, at some level, it sort of felt like we were restating the obvious with the model, but it was, it took the World Health Organization until a few months ago to acknowledge aerosolization. And we thought it was very helpful to contrast it with influenza because the epidemiology and transmission dynamics are so very different.
I'd like to come back. If other people don't have questions for Natacha, I guess I should have gone into a breakout room with her because I had a lot. You mentioned that the therapy you're evaluating is an immunotherapy. So it's essentially a pre-stimulation therapy. Can you tell us a little bit more about that approach? Because you're looking at a treatment not for specific respiratory infections, but for respiratory infections in general, which is a very interesting question. Can you tell us a little bit more about that? Because it's not so often you hear about a clinical trial for respiratory infections in general versus a specific a virus, for example. So I'd love to have some more background on that because I know you had a very short amount of time. If you could fill us in, that would be very helpful.
Yeah, sure. So indeed, this drug is composed of bacterial lysates. So it just mainly kept the protein that's on the bacteria, and that go through the digestive tract and reach the gut, where it activates the immune response in the gut. So mainly that induced regulatory response, so an immunomodulatory response, and also induced non-specific IgA antibodies, and also is assumed to induce what we call memory-like innate immune response. And we assume that all of those immune components are able to circulate through the systemic circulation and then reach the respiratory tract. And when you are in a context of respiratory tract infections, so you have some differences between the viruses, of course, but all the time you have a nexus of type 2 response with a high IgE levels and a high inflammation level. So what the treatment does is that you have a kind of innate protections from those innate memory like cells that will participate to switch the adaptive response back to a more balance between type 1 and type 2. You have the regulatory cells that will slow down the inflammation by the immunomodulation. And then you have the effect of the antibodies that are non-specific and then that can target more or less everything in the epithelium, and then decrease the number of viral particles that will enter in the lung, for example.
So you believe it works through barrier function?
So you have a barrier function, so that's mainly with the antibodies. And then if you have some viruses that still are able to cross the epithelium barrier, then you have all the immune response that start. But as you are able to balance back the adaptive response between more toward more type 1 response, and also to slow down the inflammation with the regulatory cells. So it's like it's not really like avoiding the infection, but it's more like controlling the immune response and balancing what's going on. And actually the protection, well, the efficacy of the treatment stay for a while, because you have, so the innate memory like cells, they stay longer than the usual ones. They stay for a few months, and they can circulate through the whole body. And for the regulatory T cells, it's the same, they stay for a few months. So it's non-specific activation, well, regulation of the immune response, but it's not just like innate response that's just very few days at the beginning of the infection.
And you, how serious, I mean, obviously you don't give any treatment lightly, but you had a threshold for 6 infections a year for admission to the trial. Is it based on your studies? Do you think that this is the kind of thing that could be desirable to use in a broader population?
So I didn't get your question well, because I lost the sound a few seconds. But so if I correctly understood, you're asking if the way we select the patient for the trial, so they have experienced at least five events during a year. So we should treat the patient based on this criteria, right? Is this your question?
Well, I was asking because of the efficacy you predicted was quite good.
Yeah.
Would you think that it would be worth thinking about potentially evaluating this for use in individuals who are not so susceptible? In other words, broadening the treatment guideline, the usage guidelines.
Yeah. So I don't know if you remember. So one of the plot I show you. So before exploring the context of the current pandemic, but only regarding respiratory tract infection. So the one on which we calibrate the overall model for the treatment efficacy. So you got a kind of banana shape with the data and with the model, so if you remember that. So the idea is that if you have very few infection, so the treatment will need you a lot, because you're already experiencing very few infection. And the contrary is true as well. If you is very highly susceptible because of your environment or because of intrinsic factors, then I mean, if you take the treatment, that might help to reduce the number of events, but I mean, you are very susceptible, so it will not help that much. So this is why they are focusing on the patient that are experiencing, like, let's say, a main number of infection over a year, because targeting the other one is, I mean, doesn't really change their life.
I wonder if we could get a question from somebody who hasn't asked a question. There are many people in the room I see week after week who don't ask. I see some old friends like Severine. Severine, if you're there, maybe, do you have any questions for either of our speakers?
Hello, James. It's really nice to attend these talks. And yeah, I just wanted to say that I have accepted a job at Novadiscovery. So I don't know Natacha yet, but I will know her soon. And yeah, I don't know. I think I have too many questions, but at least it's a really nice thing, and I'm really glad to be able to attend these talks.
Okay, time for one last question from somebody who hasn't spoken before. Anyone? Lisbeth, you're going to be speaking in a few weeks. Do you have anything you would like to ask either of our speakers? Not necessary. Anyone else? Last call, we're running out of time here. Lorenzo, you've been working in vitro models. What?
Yeah, I know, but tonight I'm really completely flattered. I'm really down. I don't have any good question at the moment.
That's okay. We always have a few people who ask lots of questions, and so I want to make sure that those who are not, you're not being crowded out. And is there anyone else? Because we're running out of time now. We're at our half hour. Well, I want to thank everyone then, Joshua and Natacha, for wonderful talks. I thought they went together very well. I'm looking forward to having you come back both and speak again. And I hope that the time here gives you an opportunity to talk with new people as well as old friends. I've learned a lot, and I want to thank you again. I'll see many of you next week at the steering committee meeting, and of course our speakers also next week. Thank you again, everyone, and thank you for joining us. Thank you again to our speakers.
Thanks so much. And if anyone has any other discussion points or ideas for collaboration, please reach out.
Yeah, thank you very much. And yeah, the same for us. If you want to discuss or have any question, just reach out. Thank you.
Thank you. Okay, with that, we'll call the meeting to a close. Thank you.